The last segment of the cardiac lecture will cover essentials of cardiac rhythm recognition, which is ECG rhythm interpretation. This first slide looks at conduction of the heart. So this is basically a pathophysiology review for you, where it looks at depolarization or activation of the cardiac muscle, where it's initiated from, which is the sinoatrial node in the right atrium, and how the electrical conduction travels throughout the heart. So the impulse spreads through the right atrium, then activates the left atrium, and then after that reaches that area, there's a junctional area in the AV node that travels down the ventricular septum through the right and left sides of the bundle of His, down in the ventricles. What happens then is this impulse continues down this area to the Purkinje network, which is where ventricular walls are activated and contracting then simultaneously. So this is basically the process of conduction through the heart. And remember that SA node is the area that has an inherent rate of the heart at about 60 to 100 beats per minute. Once that node or the electrical impulse hits the AV node, the inherent rate there is about 40 to 60 beats per minute, travels down the bundle of His at that point, and then down into ventricular conduction, which the rate down from ventricles, if a impulse would start in this area, would only be at about 20 to 40 beats per minute. So you can refer to your textbook for further details in this. Blood flow in the cardiac cycle is depicted here. So it just shows passive filling and atrial contraction, how the valves close in the AV areas. Semilunar valves open, the ventricles eject blood, and then there's early diastole. If we look at what exactly is an electrocardiogram, it's a graphic record and representation of the heart's electrical activity. We covered this in the very first cardiac lecture. It's obtained through an electrode placement on the body, and the electrodes will determine the magnitude and direction of the electrical currents that are produced in the heart. The ECG waveforms show the direction and electrical flow in relation to positive electrodes on the body. So for an example, for those clients that you're looking at their ECG tracings, anything above the isoelectric line, which is the flat horizontal line that would be a baseline on the ECG tracing, anything above that is showing a positive deflection, and below that would be negative. In looking at the tracing of the heart during conduction, this is just breaking down one basic heart contraction for you and breaking down the differences in the different cardiac cycles and what those are depicted as when you look on an ECG tracing of the patient. And we're going to go through in the next few slides and break this down part by part so you know what each of those little blips and bumps and things stand for. When you read an ECG rhythm strip, the first thing that you usually do is you pull off a strip from your patient's monitor, and this is pretty much what you're going to see, except that it'll have an ECG tracing on it. Along the top of the graph, this particular model here is showing increments of 1 second, but usually on most of the strips in the hospital setting, on the ECG tracing paper, you're going to notice little lines at the top like that, and those are usually representative of 3-second markings typically. If you look at all the little box patterns that you see on the ECG tracing, as you look there, you can see how one of them is taken and then made into a larger representation on the right-hand side. Each of the very small, tiny boxes that's on an ECG tracing paper represents 0.04 seconds if you look at it horizontally. If you look at it vertically, it represents 1 millimeter in height. If you take 5 of those very small boxes and you put those together, then obviously that represents 0.20 seconds of time. So when we look at a PR interval, for example, or a QRX complex, and we measure those, we're going to actually look at these boxes and measure them horizontally in order to, or longitudinally, however you want to look at it, in order to get what the correct interpretation or correct assessment would be of those different types of things. If you look at every large square being 0.20 seconds, then it would make sense that 1 minute of time would be represented by 300 large squares or 1,500 of the very tiny small squares. And this is going to be helpful to you when you start to actually look at counting a patient's heart rate based upon an EKG tracing. Once again, this is just showing that box, breaking that down even smaller, and showing how each small box represents 0.4 seconds of time. This would be cumulative. If you added it up then, 5 boxes in a row would equal 0.20 seconds of time. To break down the components of an EKG tracing, it's going to talk about on this particular slide what the different things stand for. So the baseline of the EKG tracing is known as the isoelectric line. We talked about that earlier. So if you look before the P wave, there's a flat line. That's considered the isoelectric line. If you look at the line that would be after the T wave and before the U wave, that would be considered isoelectric. So if you took a ruler and drew it straight across, that would be giving indications of where the isoelectric line is sitting. This is going to be important when we start to look at like ST segments and things like that, where we're looking for elevations and things like that. Okay. So if we break this apart, what the different parts of that EKG tracing mean, a P wave shows atrial depolarization, or in other words, atrial contraction. The P wave is typically upright and gently rounded. The PR interval represents a measurement of the amount of time it takes for the impulse to travel from the SA node into the Purkinje fibers. In other words, it's basically measuring contraction of the atria. Okay, so this is typically measured in an increment of time, and it's the normal measurement would be 0.12 to 0.20 seconds. The QRS complex represents ventricular depolarization, or in other words, ventricular contraction of the ventricles. And a normal value for this is 0.06 seconds to 0.010 seconds. The ST segment measures time between ventricular depolarization and the beginning of repolarization. So typically the ST segment, what we're looking at is if it's sitting at the isoelectric line, or is it elevated, as sometimes happens in patients that have cardiac problems. The T wave, we look to see if it's gently upright and rounded, and what it represents is ventricular repolarization. The QT interval is total ventricular activity, and this is actually measured in time. We're going to talk about normal values on that. And the U wave is not a normal finding that it's noted on the cardiac cycle. It's usually considered associated with low potassium levels or some other kinds of cardiac problems. So when we look at an EKG tracing, we're going to look at several different things. The first thing that we can do is we need to see what the patient's rate is. There's different ways that you can do this. One way is that you could look at a 6-second period of time on a 6-second strip and multiply the number of QRS complexes, which represent a ventricular contraction. So in other words, it would be the same as a heartbeat. So you could count the number of QRS contractions or heartbeats in 6 seconds and multiply by 10, and that would give the patient's heart rate. So that would be one example of what you could do. So if you looked at this particular strip, patient's heart rate, if we looked in those increments of 1 second, 2, 3, 4, 5, 6, it looks like this patient's heart rate would probably be about 60. Another way that we could determine EKG rate is by actually counting the boxes and then dividing it into the numbers. So if you remember, 1 minute of time was 300 large boxes. So if we looked at that and counted how many complexes were in there, then we could get the heart rate. So 300 divided by 5 would give us a heart rate of 60. Another method is to look at the number of small boxes between 2 R waves and divide this into 1500, and that would give you a heart rate of 1500 divided by 25, or a heart rate of 60. Probably the easiest way to figure out a patient's heart rate, however, is to just use a rate card. This is what you usually typically see most nurses that are using telemetry or have patients on a cardiac monitor using to figure out the patient's heart rate. And on the next slide, it shows you how to use a rate card. Most ICU settings will have rate cards taped right beside the monitors so that the nurses can do a real quick determination. And of course, you know, your patient's heart rate will be noted on your actual monitor screen and that type of a thing. But when you're doing it strictly off your EKG tracing, then this is a way that you can check your heart rate. So for the previous example, what we're going to do is count the number of small boxes that would fall between two R waves. We would look and see what that was. If you look at the EKG tracing that was on the previous slide, there would be 25 boxes between two R waves, and what we would do is look on the rate card for the number 25, follow it across to the right, and as you can see, that patient's heart rate would then be 60. Other questions to ask when analyzing an EKG tracing would be, are the P waves regular? Do they all look the same? Is there a P wave for every QRS? So in other words, is there an atrial contraction for every ventricular contraction? Since the PR interval represents pretty much atrial contraction and the QRS represents ventricular contraction. In some different types of conduction problems, there won't be a P wave for every QRS, or sometimes there's more than one P wave for every QRS. So when we start looking at some abnormal rhythms, we may see some funny things like that. Are the QRS waves regular and do they all look the same? Patients that have the ventricular focus come from the ventricles instead of coming from the SA node down the AV node and then to the ventricles. Patients that just have ectopic beats coming from the ventricles, you will notice the QRSs look very wide and bizarre and very strange looking. Does the rate look slow or fast? Is it regular or irregular is another question to ask. Next, you want to determine the rate, which we've just figured out how to do. And then you want to look at what are the measurements for the PR interval, the QRS interval, and the QT interval. And then lastly, once you've done all that, you can actually identify what the rhythm is. This lecture just gives you a quick overview on some of the most common tracings that you may see. Once you get into practice, if you decide to work in a cardiac intensive care unit, you will get probably a couple of weeks, if not longer, of classes that will deal with how to actually interpret EKG tracings and those types of things. And you'll get a much more in-depth class that will talk about more analyzing abilities and things like that of the tracings. So items to measure to identify rhythms, we've kind of mentioned before. You need to know the PR interval, the QRS duration, the rate, which you can measure by counting from R to R. And then you can look at ST segment, is it at the isoelectric line? The T wave, is it upright and rounded? And what is the measurement of the QT interval? Some units may actually measure the length of an ST segment and the length of a T wave, but typically when nurses put it on an EKG tracing, you'll just typically see them. The only measurements you'll usually see recorded is PRS, PR, QRS, and QT. Here are normal values for all of those things. P wave should be smooth, rounded, upright. PR interval should be 0.12 to 0.20 seconds. The QRS complex should measure 0.06 to 0.10 seconds. The ST segment should sit on the isometric line. The T wave should be smooth, upright, rounded, and less than 10 millimeters tall. And the QT interval should be representative of somewhere between 0.32 and 0.44 seconds if the patient has a heart rate within a normal range. QT intervals for children are different, and we're not going to go over pediatric normals. That'll be something that you can cover at a later date. U wave, like I said, is not typically seen. It's a lot of times represents a low potassium level on patients. After all of these measurements have been completed, then it's time to identify what the actual rhythm is that the patient has, and then what nursing interventions would go if it turns out that that patient does indeed have an abnormal rhythm. And that's where the rest of the lecture will go. What we're going to do now is we're going to go through rhythm strips, and we're going to look at what are normals, what are abnormals, what would be causes, and what would be interventions for some of these different abnormal rhythm strips. So hopefully by now in clinical you've been able to pull off some rhythm strips from your patients and been able to interpret them with the help of your clinical instructor. So hopefully by the end of this lecture you'll feel a little bit more confident and be a little bit more independent with being able to look at rhythm strips and being able to interpret what's going on. This very first one is just going to look at a normal sinus rhythm. This is what is considered the best of what you would like to be in with your cardiac ECG or EKG tracing. Normal sinus rhythm means that there's normal conduction going on through the heart. The electrical impulses are all working fine, and everything is as it should be along the conduction pathway. So if we look at parameters for normal sinus rhythm, the rate is going to be somewhere between 60 and 100. The rhythm should look regular, so all P's to P's should measure regular and the same. All R's to R's should measure regular and the same. There should be one P wave for every QRS ratio. The PR interval should be 0.12 to 0.20 seconds, and the QRS should measure 0.06 to 0.10 seconds. So obviously no treatments needed because this is normal sinus rhythm. Sinus bradycardia, you're going to see that the only difference here is just that the rhythm is slow. Everything else is considered within a normal pattern. And typically nothing needs done with sinus bradycardia unless that patient's heart rate falls so low that the patient's having a poor cardiac output from it. So for example, those patients that maybe just have a heart rate in the 50s, that maybe just be perfectly normal for them, especially if it's a person that's athletic. I've heard Lance Armstrong's heart rate's typically in the 40s. That's nothing to worry about. He has a very efficient heart because of all the exercise that he does, and that's just a normal finding for him. He has a good cardiac output with that, so obviously there would be no intervention that would be needed. Another patient that would fall in the 40s, that might be symptomatic for them if their normal heart rate's normally in the 80s. So it's very dependent on that person's physical condition and underlying causes of what caused the sinus bradycardia. Parameters for sinus brady, the heart rate needs to be less than 60. The rhythm is regular. P to QRS is 1 to 1. PR interval is 0.10 to 0.20. And the QRS is 0.06 to 0.10, which is normal. So like we said, causes for sinus brady could simply be that that patient's in great shape and there's nothing wrong, or it could be because of physical problems such as increased vagal stimulation. Anytime a patient has vomiting, straining, coughing, you're suctioning them, anything like that, that can stimulate the vagal nerve, which can cause the heart rate to go slower. So some people have a slower heart rate when they're sleeping, obviously, than when they're awake, and some people actually may have a heart rate down in the 50s as they're sleeping. Patients that are post-MI or hypothyroid sometimes will also have low heart rates, and patients taking drugs such as beta blockers, calcium channel blockers, things like that. If their drugs are at too high of a dose for them, it may cause their heart rate to go too slow. So in one of the cardiac lectures, we talked about the importance of teaching patients that are on these cardiac medications to monitor their heart rate to make sure that they're within a normal range and those types of things. Patients that have increased intracranial pressure will also have low heart rates, and patients that are hypothermic or in pain. Typically, the treatment is going to be atropine if that patient is symptomatic. That would be the first intervention. If it's an extremely low heart rate and it's due to maybe a heart block in addition or something like that, the patient may require a pacemaker or medications such as dopamine, epinephrine, or an isoprel drip. The opposite of this would be sinus tachycardia, and this would be for a patient that obviously has a heart rate over 100. This one is where the sinus node creates an impulse faster than normal rate. And typically with these patients, they may be in a normal sinus rhythm. Everything looks normal except that the heart rate is fast. With patients that have too high of a rate, let's say if they're 120, 130 with their sinus tachycardia, this is going to lead to decreased cardiac output because the heart can't pump effectively and have a good contraction when it's beating that quickly. So that patient may feel short of breath, dizzy, and have hypotension and those types of things. So it's, once again, you treat the patient and find out what exactly is the underlying cause and if that patient is having symptoms with that particular sinus tachycardia. The parameters, the rate's going to fall above 100 and up to 150. The rhythm will be regular. P to QRS is going to be 1 to 1. The PR interval is going to be 0.10 to 0.2 seconds, and the QRS is going to fall within a normal range. Causes could be some sort of a stimulant, such as caffeine, to the nicotine from tobacco, things like that. Could be exertion. The patient that just ran up a flight of stairs obviously could have a short run of tachycardia and then have their heart rate go back down to normal. If that patient has heart damage, that patient may have tachycardia on a permanent basis. Fever also causes the heart to go fast. Could be fear, anxiety, excitement, pain, hyperthyroidism. Could be medications that patient has been given, such as atropine, or the patient has taken, such as amphetamines, that type of a thing. Or it could be that the patient's tachycardia because they're hypovolemic and the heart's trying to compensate for the lack of blood volume. If they're symptomatic, they may be treated with digoxin or a beta blocker to slow down the heart rate. Calcium channel blockers will also decrease the heart rate. And one example of a calcium channel blocker is diltiazem, which is listed there. Sinus rhythm with a bundle branch block is depicted by this one. And when the bundle branch is blocked, the impulses must travel a different path to stimulate the ventricles. And that's why you see the QRS complex prolonged and widened instead of what a normal QRS would look like. This is an example of atrial fibrillation. And atrial fib causes a rapid, disorganized, uncoordinated twitching of the atrial muscles. So it's not a good contraction of the atria. It may stop and start suddenly. It may occur for a short time, or it could be a chronic problem with some patients. And it just depends on what the ventricular response is to that, as far as how symptomatic the patient is. Typically, the patient loses what's called the atrial kick when they're in atrial fibrillation, and that would be the last part of ventricular filling. If you think about how blood flows through the heart, by gravity, about 75% of the blood flows from the atria to the ventricles, but that last 25% of the blood gets from the atria to the ventricles by that atrial kick or that atrial contraction. With atrial fib, you lose that atrial kick or contraction, so the blood tends to pool in the atria. It doesn't get out as it should, which leads to a risk of the patient forming blood clots or embolus. So with this, one thing that we really worry about is that patient developing a blood clot, throwing it, and developing like a pulmonary embolus. That's a real big issue for these particular patients. So parameters for atrial fib, the rate can be anywhere from 300 to 600 for the atria. The ventricle response could be anywhere from 100 to 180. The rhythm may be regular or irregular. It just depends on how the heart responds to that. And the P to the QRS is usually variable. PR intervals, you're not going to really be able to measure P waves or a PR, as you can see, because it was just basically a real wavy type of a line. The QRS is usually okay at 0.06 to 0.10. There are many, many causes and treatments of atrial fib. Those are listed here on the slide for you, and there's more information given in your speaker notes. One way to treat it is either by medications. Those are listed. Verapamil, dig, beta blockers are very common. The patient, because of the risk of throwing a pulmonary embolus, is placed on anticoagulation therapy, dysrhythmic types of medications, antidysrhythmics, and the patient may undergo a cardioversion technique. Basically, cardioversion is with this, it reprograms the heart. It'll almost look as if the patient is getting defibrillated. However, we set the defibrillator on a special mode for this. We put it on a synchronized mode so that it synchronizes with the R waves, and the patient is usually given less joules or shock potential with this particular treatment method. And what it does is it hopefully overrides what the atria are doing to get the patient's heart back into a normal sinus pattern and those types of things. So many times this patient may have this done on an elective procedure, and the patient will be sedated with medication before it's done. And the patient obviously is in a center where, in case the patient would have an adverse reaction to it, the patient needs to be set up where there's everything, resuscitation equipment nearby and available for that patient, just in case there would be a adverse outcome from the cardioversion. This depicts atrial flutter, which is similar to atrial fib, except what's happening is the atria flutter is occurring in it. The impulses in the atria are usually typically between 250 and 400 beats per minute, and the atria rate is beating quite fast through the AV node, faster than it can conduct, so not all atria impulses are conducted in the ventricle. So what you get is a therapeutic block going through the AV node. So with this particular one, typically the patient may feel chest pain, have shortness of breath, feel palpitations, have poor cardiac output, and low blood pressure, which can lead to decreased level of consciousness and those types of things. So what you see here is this particular patient has a 3-to-1 heart block. So in other words, there's 3 atrial contractions for every 1 ventricular contraction. So this is actually how we would chart it, that the patient's atrial rate was 240 to 360, that the ventricular rate varied. The rhythm, there's typically more P waves than QRS. With the PR interval, there's really no true PR interval, but with this particular pattern, we would see what the ratio was. It could be 2-to-1, could be 3-to-1, could be 4-to-1. The particular one that we saw on the previous slide was a 3-to-1 pattern, and you saw those sawtooth patterned F waves. The QRS was 0.06 to 0.10, which is considered normal. Causes of this: coronary artery disease is a common cause, patients that have a pulmonary embolus, mitral valve problems, possibly post-thoracic surgical procedures, the patients that have chronic obstructive pulmonary disease or myocardial infarction, patients that have had caffeine and alcohol intake, those types of things. And then treatment, once again, is going to be with calcium channel blockers that are listed there, like cardizem, DIG, beta blockers, amiodarone, atropine, cardioversion, and pacing if needed. This depicts a premature atrial contraction. Sometimes you'll actually see where the impulse starts in the atrium outside of the atrial node, and so you'll notice that that is out of sync with where the rest of the EKG, QRS complexes and atrial complexes are, and that's just because it's kind of doing its own thing from like an ectopic beat. Premature atrial contraction parameters are listed here for you, and typically as long as that patient doesn't have any symptoms with it and that patient doesn't have a poor cardiac output and it's just once in a intermittent type of a thing, then typically a lot of intervention isn't needed for those. Sometimes you'll see it with patients under a lot of stress or that have had a lot of caffeine and tobacco on board. Sometimes you'll see it with your patients that are post-MI or heart failure, that type of a thing. And other causes are listed there for you: atrial enlargement, infection, inflammation of the heart, ischemia, pulmonary embolism, and those types of things. Like I said, if that patient's asymptomatic, we don't really worry about it too much. It's pretty much a benign rhythm, and you're only going to treat it if that patient is symptomatic and has a lot of PACs happening. And then we might be using something like beta blockers, or just eliminating whatever the cause was if it was something like caffeine and alcohol and tobacco excessive intake. Premature ventricular contractions. This is a EKG pattern representative of what those look like. And with this, the focus actually starts in a ventricle, and it conducts through the ventricles before the next sinus impulse. So sometimes healthy people will have one of these occasionally. What we worry about are premature ventricular contractions, or PVCs, that are more frequent than 6 per minute, that are considered multifocal. In other words, they look different. They come from 2 different ectopic focuses or foci in the ventricles. For any that occur 2 or more in a row, or when you have, what we worry about is any that occur on the T wave. We're going to talk about some issues with some of those types of things. PVCs can also occur 2 in a row. Those are called couplets. 3 in a row are called triplets. They can also occur every other beat, which is considered bigeminy, and every 3rd beat, which is considered trigeminy. Parameters, the rate's going to be determined by the number of PVCs. The rhythm may look very irregular because PVCs are typically followed by a compensatory pause. There's going to be no P wave before the PVC because it's coming from an ectopic focus. The PR interval is going to be absent during the PVC, and the QRS is going to look very wide and bizarre and be greater than 0.12 seconds, so it's way over the normal parameters. Causes could be heart disease or failure, digitoxicity, hypoxia, stimulants, patients that have electrolyte imbalances. And if the patient has a lot of these, it could be a warning sign for acute heart disease or MI, different things like that. Sometimes mitral valve prolapse will also have this, or excessive caffeine and alcohol, or aminophylline, which is a medication used for bronchospasm. Treatment, if they're symptomatic, if patients only have one of these once in a great while and they're not symptomatic, we won't worry. But if the patient does have, where we talked about before, 2 together, 3 together, if they have more than 6 in a row, or if the patient has any of those multifocal PVCs, things we talked about on a previous slide, then we would go ahead and treat them. This is an example of a multifocal PVC. As you can see, the 2 PVCs look different from each other, and the reason for that is because they're each coming from a different foci or a different point within the ventricles. Here's an example of couplets. So you have 2 PVCs in a row. And the thing that we worry about with PVCs is if you have 3 or more PVCs in a row, this would be ventricular tachycardia. Obviously, this is 1 PVC after another with this particular tachycardia. What happens is the patient has very, very poor cardiac output when this happens, and it can lead to hypotension and shock and a weak or non-palpable pulse. It's very important when you see abnormal rhythms on patients to always treat the patient first and treat the monitor second, because especially with PVC, there's sometimes there's PVC with a pulse, and there's VTAC with a pulse, and there's VTAC without a pulse. So sometimes you might see this on your monitor, and you might go into the patient's room and find that patient conscious and alert, but with a poor cardiac output and a poor blood pressure. Sometimes you might go in and find that patient completely unresponsive, not breathing, and no pulse whatsoever. So look at the patient before you treat the monitor and that type of a thing. I have a cute story from when I worked in cardiac intensive care. It was change of shift, so there were lots of nurses around the monitor giving report. We did oral report between the shifts, and we all happened to hear a monitor alarm at the same time, looked at it, saw that there was a patient that was in VTAC. So some nurses ran straight to the room, some nurses ran and got the code cart and all of the things that you'd need to run a code. We all came charging in this patient's room, and only to find the patient sitting in bed, kind of looking around. The patient was alert, and one of us asked the patient how he was feeling, and he looked at all the equipment and all the nurses in the room, and he said, "I guess not so great, huh?" So that's just kind of a cute story where you always want to make sure, treat the patient first, treat the monitor second. Typically, patients with this, if they are alert, will complain of palpitations, dizziness, chest pain. They're going to be short of breath if they are conscious. Many times if you see a patient in VTAC, you're going to walk in and you're going to find the patient unconscious and without a pulse. Here are your parameters for VTAC. As you can see, the rate's going to be 100 to 250. The rhythm may look regular or irregular. There's not going to be P waves before the QRS complexes, and so obviously you can't measure a PR interval, and the QRS is going to look wide and bizarre, so it's going to be over the 0.12. Causes are listed to the left. It could be a potassium or electrolyte imbalance, drug toxicity, bradycardia, ischemia, coronary artery disease, could be a patient that's post-MI or a patient that has cardiomyopathy. If they have a pulse and they're alert, then with those patients we're going to treat them with medication. We can give lidocaine, amiodarone, procainamide. We might do cardioversion on those patients. However, if you walk in and the patient is in VTAC without a pulse, that patient would be unresponsive, no pulse, no breathing, that type of thing. That you're going to treat differently. That particular patient, you're going to go ahead and defibrillate, and you're going to start CPR in those patients. VFib is represented on this particular rhythm strip. As you can see, it's very chaotic. It's very strange looking. This is basically the ventricles are just quivering. They're not doing conduction whatsoever. And so obviously cardiac output is very poor and that type of a thing. So just to give you some statistics, the best way to treat ventricular fibrillation is to do defibrillation on the patient to get the patient hopefully back into a normal sinus rhythm. And this was one reason that there was the development of automatic external defibrillators, or AEDs. Just to show you some statistics with that, the survival rate with patients that have had VFib and then been resuscitated with an AED is about 49 to 70% with a witnessed event. Versus worldwide, if you look at stats, patients that are brought to a hospital that have been in VFib and have been essentially in cardiac arrest without the benefits of an AED, probably less than 6% of those patients survive. So AEDs have been a wonderful development. VFib parameters, the rate you will not be able to determine. It's too rapid to count. The rhythm is going to be totally chaotic and irregular. There's going to be no P waves, no PR interval, and the QRS, you're not going to be able to measure it at all. Causes are listed there. It can be many causes such as heart disease, hypoxia, electrolyte imbalances, coronary artery disease, ischemia, dig toxicity. Could be the patient had received an electric shock or is in metabolic acidosis, or they're on antidysrhythmic medications that are too high of doses and different things like that. So we talked about already, treatment is going to be to defibrillate and start CPR with that particular patient. So this would be the patient obviously that you're calling a code for if this happens in the hospital setting, and following ACLS guidelines, which is advanced cardiac life support. This is a depiction of asystole. The ECG tracing is basically a flat line. There's no electrical activity noted at all. The pacemaker cells have essentially failed to work whatsoever. So this patient will be unresponsive. No heart rate, no pulse, no blood pressure, no breathing or anything like that. So this particular rhythm is a very difficult one to treat because there's essentially no electrical activity left in the heart whatsoever. At least a patient in VFib has some electrical activity. It's very chaotic, but at least you have something to work with. The patient with asystole is very difficult to bring these patients back once they've developed asystole. And as we said, there's no rate, rhythm, no P waves, or no QRS complexes with this one. The way that we're going to treat them is we're going to do CPR. Defibrillation doesn't really work well because there's really no electrical activity going on in the heart with this. The best way to treat it is to figure out what caused it in the first place and to try and treat the cause. So the last part of the ECG lecture is going to talk about atrioventricular blocks. You may see these on your patients, so we will just cover them very, very briefly. What this is a black to an impulse conduction. It occurs at any point along the conduction pathway, and there can be first degree blacks, second degree blacks, which actually there's two different types of second degree blacks. There's a type 1, which is called a Mobitz 1 or a Wenckebach, and there's a type 2, which is called a Mobitz 2 type of a black, and then there's also third degree or complete heart blocks. First degree heart blocks with this, those basically, the blocks are often transient, they're many times reversible, and it's just where you have a longer PR interval. That's basically the only thing that's different with a first degree heart block. So the rate's typically 60 to 100, rhythm is regular, QRS is 1 to 1 from the P to the QRS. PR interval is long, like we said, it's more than 0.21 seconds, and the QRS is normally fine. Causes are listed here. Treatments are usually not treated unless they're symptomatic with it. Usually we just monitor those and try and resolve whatever caused it. A second degree heart block is also known as a Mobitz 1 or a Wenckebach, and with this one what happens is you have longer and longer PRs until eventually a P wave is not followed by a QRS. That's essentially what's happening here. You can read through here the rate's typically 60 to 100. The R to QRS ratio is 1 to 1 until that P wave gets blocked. The PR interval progressively gets longer until you have an impulse that's blocked, and QRS is usually typically within normal limits until you have that blocked one. Causes are listed, could be ischemia, electrolyte balances. Patients have had an acute inferior wall MI. If you remember from a previous cardiac lecture, we talked about the different coronary arteries and which ones feed the SA node and AV nodes. So if one of those coronary arteries were affected, then that could affect their rhythms and their conduction through the heart, those types of things. Treatment, many times these patients are asymptomatic. If they're not, if they do have symptoms, then we can go ahead and give them atropine if we need to increase the cardiac output, or if the patient's having symptoms with it. A second degree heart block is known as a Mobitz 2, and with this one you have some P waves that are followed by a QRS. Some are not followed by a QRS. So here are your parameters, which I will let you read through. The P to Ps are regular, the R to Rs are regular, but not all Ps are followed by a QRS. So sometimes you'll have a 2 to 1, 3 to 1, or 4 to 1 blockage, that type of a thing. The QRS is typically normal. Here are causes and treatments. Rheumatic heart disease as well as anterior wall MIs, digitoxicity, coronary artery disease, cardiomyopathy, chronic fibrotic disease are some of the common causes that we see with this particular type of heart block. And the treatment is typically a temporary or a permanent pacemaker and or atropine. What we worry about with this is it can progress to third degree heart block. And with this particular heart block, as you can see, the atria are pretty much doing their own thing. The ventricles are pretty much doing their own thing, and neither one is talking to each other. So that's the problem that we have. The rate, atrial may be 60 to 100. Ventricular rate may be anywhere from as low as 15 to as high as 60. The rhythm is typically, if you look at them separately, regular. The PR is not measurable, and the P to QRS, there's typically more Ps than QRSs. And essentially no relationship is going on between the atrial and ventricular conduction. A lot of times the QRS is kind of wide and bizarre if it's coming from a ventricular focus. The causes are typically a patient that's a post-MI, digitoxicity, severe heart disease, and the treatment for these patients, they do require a pacemaker. In the interim before a pacemaker can be put in, they may require administration of epinephrine. When we look at different types of pacemakers, we talk about temporary or permanent. The patients with the conduction difficulties we've just talked about, particularly third degree heart block, are going to have a permanent one put in. And then you can refer to your textbook for care after insertion of a pacemaker and those types of things. This gives a depiction of a temporary pacemaker, which would be external to the body, versus a permanent, which is actually implanted within the chest wall, and then it's all regulated through a pulse generator and through an internal pathway into the heart. What we look at when we look at pacemaker tracings is if there's a spike when the pacemaker fires, so that's what we look at, and you can kind of see that dip and spike that happens before a contraction. So that's what we look to see, is if the pacemaker is firing correctly and if the heart is capturing that spike. This is an example of ventricular pacing, so you can see the ventricular pacer spike, and we can see that we do have one-to-one capture here. For every one pacemaker spike, you can see that it's followed by a contraction with the ventricles. This is a depiction of an implantable cardioverter defibrillator known as a ICD or AICD, it's sometimes called, sometimes an automatic ICD. It's an implanted device and has cardioversion abilities, has defibrillator abilities. So this would be for the patient that's perhaps a post-VFib patient that was actually recovered. The patient was brought in, treated for VFib, and actually lived through that experience. And if they have a risk that that patient's going to have another arrhythmia, such as another VFib, the patient may be a good candidate for an AICD machine. You can read more information about this in your textbook. Here are a couple of NCLEX questions on EKG tracings. We had a lot of information in this particular lecture. Hopefully by reading your textbook and by what you've been able to practice in your clinical setting with your clinical instructors, you'll feel a little bit more comfortable and confident with your EKG interpretation techniques.